All right. We recorded. First thing, today's the last of the formalized anatomy lectures for sure. We're going to finish it relatively quickly. What I like to do is, let's say it's unlikely we will be here on this Friday or next Friday.
No Fridays.
Well, so my guess is the times we're together are, other than today, and I'll start with a particular group of diseases because they're pertinent to what we're studying. Urinary tract diseases, etc. But if you have any interest, because you don't have a chance to discuss these when you do micro, or you guys when you do micro with Dr. Maurer, because it's not really his area of expertise, where to some extent it's mine. So if you want to know how a certain disease impacts, how you go about treating it, what are the ramifications, how does it work, almost like medically, anatomically, physiologically, this is the time to generate some questions and send them to me. Whether it's how a bad wound heals, which I really have probably as much expertise, or a bad fracture, we talked about that a little bit. Those kinds of things, this is the opportunity. So I take one of the micro texts that I'm most familiar with. Did you use Nestor for micro? You probably did, I would think. Nestor's micro. You didn't? Looks a little bit like this. No, okay.
No, we use
You use Cowan?
Pearson.
Oh, Pearson.
I think it was a Pearson.
There's a Pearson in micro? Heavens. Well, basically, this is more oriented. They have a fairly substantial amount of diseases, and they do diseases systematically, which I think is interesting. So it gives me an opportunity to share a little bit of information to you, none of which you'll be tested upon, but something so we could share some time together. I think most people will benefit to a certain extent. Oh, excuse me. Speedy delivery. Thank you. Good. Great. I got my little thingy. Thank you. Bye-bye. It's back.
Personal delivery.
The speedy delivery.
Okay.
He's related to Mr. McFeely.
Oh.
You remember him?
What's your name?
Mr. McFeely. Oh, you're terrible. From Mr. Rogers.
Oh, that happened in my hometown.
For sure. Speedy delivery.
I've never seen it.
You never saw Mr. Rogers.
No.
I told you that story, right? I didn't. I do it last time. Forget it. We'll see. If I didn't, I'll work on a new story. Off we go. So let me finish up. This is the end of the female reproductive anatomy portion of the program, and I just checked back because I really, frankly, hadn't looked at it. It's a much more physiologically impactful system and chapter than it is anatomical. So we have a little bit left to do with a few of the systems, and based on what I saw, we had kind of gotten more or less toward here. Okay, and so I'll just start with the uterus, even though we probably went over it a little bit. That's there, and so it's for internal anatomy, uterus and vagina. If we have the external anatomy, we have the breast as part of that, and that basically concludes the anatomy part of the program. Yes, ma'am.
Do you have any other tests in lab?
Yeah, I will probably generate another take home for you to take, rather than have you sit here on Monday afternoon taking the test. What?
Before next week.
No, as long as I get it in my hot little hands by the end of prior to the start of finals, I'll be happy.
Okay, and then the final for here will also be online.
Yeah, I'll be on Blackboard.
And that'll be Wednesday.
Wednesday.
Okay.
Sometime I forget when it is. It's in Wednesday. What? I don't remember if it's 11 or what. I know, but I know it's 11 o'clock unit to 1:30, whatever.
We have a certain window to do it.
Yeah, you have the window. That way, it's the most important thing from Blackboard when you take a test on Blackboard is your internet connection, because it is a real pain when it drops. Okay, because then I have to revamp and reset up the whole test, and it screws up everything. So, I mean, it's going to happen. So hopefully it doesn't happen to this group because there's only 16 of us to deal with. But, that's why when we do those things on Blackboard, basically, if there's questions, just text me. So you're at home or whether you're here at school or whether hopefully you're someplace warm and sunny on the beach taking it, which I would recommend. And I have done that. Though my wife and I are not leaving until the 18th for a few sunny days in Orlando. We have room. So, you got a problem with that? Get over it.
What do we come with?
Nothing. Yeah. But don't tell anybody that you're coming along with my wife and I to Orlando.
Okay. I don't know where I'm going, but yeah.
What?
What?
Yeah, that on the 18th to the 22nd.
Okay.
We'll hide you in the luggage.
I'm going on vacation.
Yeah.
Oh, okay. Yeah. That works.
Terrible. Moving on. So the end of the female reproductive anatomy we start here with the uterus. So the uterus itself, effectively, it's just a large muscle container, for lack of a better description. And like many, many structures anatomically, it has this consistent triple layer aspect. The outside, again, is serous. It's really just part of the visceral peritoneum, not unlike what's external to whether it's the kidney or the intestines or anything like that, moist because there's a certain amount of movement that goes along with it. The significant feature is not necessarily the myometrium, interlacing layers of smooth muscle. And those interlacing layer, obviously, with the rhythmicity of contraction associated with childbirth, are significant as well. The key player here is the endometrium. So it is a mucosal lining of two layers, one that is always there, even though it's being modified over time, and one that is replaced cyclically. So you have two strata. Remember, the word for layer is strata. You have the stratum basalis, the layer that's always there, the base layer, and what starts at the start of each menstrual cycle and sheds in the absence of implantation is the stratum functionalis, and you'll see that shortly. So it's simple columnar epithelia. It has a rather substantial underlayer of lamina propria, and it's all about and that's really to me the crux of understanding when we talk about anatomy in any stretch is you look at what its purpose is to kind of understand a little bit about how things work. So the two major layers, the functionalis, that's the ones that's sensitive to hormonal development. You'll see when we get into physiology in the early phase, in the pre-ovulatory phase, it's all about increasing it and growing it to a certain point. In the post-ovulatory phase, it's all about expanding it and preparing it for the possibility of implantation of a fertilized egg. And in the absence of that second or last event, we have menstruation. And again, when we talk about the misunderstanding, it's just like the misunderstanding about a lot of things. It's menstruation is not as much blood as one would think. It is mostly fluid and it is mostly tissue. Okay, there's a certain amount of blood, but it's the old saying, a little bit of blood goes a long way. And this is the basic way to understand. If you had a gallon of water and a thimbleful of blood and poured the thimble into the water, it would all turn red. To give you an idea of how effortlessly, if that's the right word, that the blood will discolor a rather substantial amount of fluid. So you're not talking about it in an immense amount under normal circumstances. The basalis is the base that forms the functionalis. And it is always there, and it doesn't necessarily, is not impacted. And we go over this all again. The crux of the physiology in female reproductive is the marriage between the ovarian cycle and the endometrial cycle. Those are the two cycles that really dictate how our understanding and then what hormones are active or what messengers are active at what particular time. So here's a micrograph. And so you can see here, this is muscle. It's hard to determine whether it's interlaced just by looking at that. This is the base layer. You can see there's a certain amount of space, and those are probably, again, to some extent, glandular tissue that's not immensely functional at this point. And now you can see a fully developed functionality. You're able to tell that when we begin to see lots and lots of glands and lots of, I turned off the ringer, apparently not. We'll have to let him know. Hold on, we're getting there. I'll turn it off. The bottom line, don't have children. Got it. Good. And so we have that going on. So when you see the development of the glands, a substantial amount of venous blood is in there, and that's probably where the color of the menstrual fluid comes from. Interestingly, the anatomy goes on specifically. Remember, there's different. The gonadal arteries are the ones that supply the ovaries or the testes. So in the female, obviously the ovaries. The uterus itself takes its blood supply from a branch of the internal iliacs called the uterine arteries. And the uterine arteries enter the uterus, and just like we remember in the kidney, when you see arcuate, they arch over, let's say, the perimeter of it, and then you begin, just like again in the kidneys, then you have radiate. You have vessels that come off those arches pointing toward the interior. And what happens in the basalis, they're straight arteries. But when they get into the functionalis, they spiral. And it's that spiraling of the arteries that's very significant. They're the ones that are extra sensitive to the absence of hormonal levels, particularly, as you will find out, progesterone. So when in ovulation, in the absence, just to give you a heads up of what's coming down the road next term, progesterone is the predominant hormone that causes this expansion of this layer. What happens, in the absence of fertilization and implantation, the shell, the external shell of where the egg was ejected is called the corpus luteum because it's yellowish color. It functions for 10 days. When there's implantation, it will function for months until the placenta develops. But in the absence of implantation, after about 10 days, it stops. That relatively sudden stoppage causes these spiral arteries to go into spasm. And so when something spasms in an artery, if you put a tourniquet on, and that's the best analogy, if you put a tourniquet, as we used to do all the time for upper and lower extremity surgery, what you build up behind that tourniquet, even though there's no blood going down here, is a pressure. So once that spasm releases, the pressure kind of pushes out. Rather, it's like holding something back, letting it go, and boom, it comes this way. What happens when that spasm occurs, the tissue at the interface between the basalis and the functionalis dies, so to speak, because that's right where the spasm occurs. It starts to separate, and then once the spasm releases, that sort of jet stream of blood, if you want to think of it that way, that increased amount of flow causes the separation that we refer to as menstruation. That's the events that go behind it. So the spasms lead immediately, the shedding comes first. The spasm creates an interface that dies, weakens, and then off it goes. So here they're showing you arcuate arteries that are going straight, okay? So they radiate, in this case going straight, and then they're straight here in the lower levels, and then they start to spiral. So this is very, very well developed. And the highlight of well developed is this, the development of these glands rather going substantially all the way down into the area of the smooth muscle. So that's sort of the background that goes along with it. So we'll explore that more and look at the timing of the events when we do the physiology. So the vagina, 3 to 4 inches, thin wall, birth canal, they call it the copulatory organ, passage for menstrual flow between the bladder and the rectum. Cervix is the neck-like area in between the uterus and the vagina itself, going exterior. The urethra parallels it, but is anterior to it. So its nature is fibroelastic adventitia. So it's not designed for movement, but the elasticity So it's not serosa with a moist lining, adventitious a firmer lining, but the elasticity allows it during the events of copulation to function appropriately. And then you have relatively smooth muscle in the muscularis. And again, once you make the change here, so it's overdeveloped symbol columnar in the uterus. Now, as we're heading toward the exterior, so to speak, we make this transition to stratified squamous non-keratinizing. Okay. And then rugae are there. There's a ridged aspect to it as well. The secretions are acidic in the adult female. That's something we go into a lot. And when I do the micro part of it, when you talk about lactobacillus, maybe you discussed it, maybe you don't. You didn't when you were in micro. Lactobacillus is a very fragile, uh, normal flora, normal microflora, normal microorganism that is found in abundance in a lot of areas, particularly female reproductive. It's the one that's highly sensitive to antibiotics. I mean, if you show it a label of a strong antibiotic, it die. It's one of those. And so that's why we have a tremendous amount of problem if you're a prescriber. When someone comes in with any kind of an infection, you give them, let's say, a prescription for Keflex. Very, very common, known as cephalexin generically. And more than half of all prescriptions written are for cephalosporin products, just to give you an idea. People who are either predisposed to urinary tract and vaginal yeast infections, a fair amount of them develop it. In my population of diabetics, an immense amount developed it. Why? Because the protection against those infections is the acidity. Lactobacillus thrives on glycogen. Progesterone and estrogen create an abundance of glycogen in and around that area. So the lactobacillus flourishes. In the presence of a broad spectrum antibiotic, it dies. And at that point, you no longer have lactobacillus tells you what it makes, lactic acid. You lose the acidity is the barrier to infection. The acidity is the key. In premenopausal and postmenopausal, the mucus is the protection. And that's what they're driving at here. So whether that was explained to you or not previously, and about a third to a half of us typically have Candida albicans, which is an extraordinarily common yeast, as part of our normal flora. And it overwhelms it. I get something because I take immunosuppressants called thrush, okay, which is the mouth version of that. And every so often, usually after typically periodically, maybe 2 or 3 times a year, and I have to do lozenges of clotrimazole. And that's the standard. If you look for it's called Lotrimin. It was a trade name, clotrimazole, and they do it with lozenges now. You have to do like 5 of them a day and let them dissolve in there to do that. And for women with vaginal yeast infection, there's a variety of ways to do it. Most of my success came from using diflucam, okay, which is an oral agent, which is very effective. I had a Post-it note on my charts. Okay. With diabetic patients who are predisposed to that, because they get a lot of infections. And the Post-it note said, you had like a letter D on it, which meant if you're prescribing an antibiotic, here's a prescription for diflucam to take. You take 1 pill, and it's like 3 doses that are, they're released on a time release pattern. Never had a problem with it. So, little tip, okay? So, vaginal orifice, incomplete partition, the hymen ruptures during the initial intercourse, okay? There's not a whole lot else. That's the vulva itself. Again, that's the perineum. If you want to refer to it in the female, it's called the vulva. You have the mons. You have the clitoris. The clitoris has a prepuce or a foreskin. Again, the analogy to the penis in the male. The opening is the vestibule. This is one where the hymen is ruptured. So you can see more acutely anterior to the vaginal opening. You have the urethra. Posterior, you have the anus. And so, again, in the male, we see the distinct difference anatomically and the predisposition, not just to the yeast infection, but the proximity, particularly people who are incontinent or aging, or a variety of other circumstances, the predisposition based on anatomy toward urinary tract infections. Most urinary tract infections, 60, 70% of them are from something you're very familiar with, E. coli. Okay, they're gram-negative rods that are associated, that are basically fecal in origin. And yes, they can be related to inappropriate hygiene. Frequently, they're associated with incontinence. Uh, there's other factors. Some people are just much more predisposed to them. Sometimes it can be frequency of intercourse related. There's a variety that go on that are there. So the uterus tilts away, and this is the thing, without getting into a discussion about abortion, which is really it's such a difficult topic, because people have strong opinions, and you tend to, I don't think they work well in a science class, frankly. That's code for I don't want to discuss it. Okay. Right. It probably is a good idea. Okay. Short story. The reason Roe v. Wade was enacted in 1974, people used to go to anybody or try to do it themselves, these self-induced abortions, coat hanger abortions. They didn't understand the anatomy. They didn't understand the anteverted position of the uterus. Gangrene of the uterus, things like that. Terrible, terrible, horrible. People dying from failed attempts. Medicines that were, old herbal remedies that dated back to effectively the poisons. There's a whole lot of it. Even one that was, it was characterized in a very, very interesting piece done on HBO, not a piece, but a series called Boardwalk Empire, where the women would drink non-pasteurized milk because it had a lot of E. coli, and try to induce an abortion that way. Okay, so because these were the days when unpasteurized milk is just that. You can make, you just don't go through the pasteurization process. Some people who are used to drinking have no problem with it. People who are not, you can cause significant problems. It means it's basically milk with E. coli in it. Because we used to do it in the lab. We let you run this experiment on pasteurized, which you go buy at the store, versus unpasteurized, buy at the store and add some E. coli to it. Just give you an idea. And so there was a horrible thing, and that was part of what was going around at the time, at that time. And understand the era of that time were late 60s, early 70s. There was a different mindset. And understand we could not, certain words were not in the lexicon, most notoriously something called HIV, which nobody knew about. People thought the notion that having sexually transmitted, that having diseases spread by way of intercourse was still foreign to a lot of people. It has a misunderstanding that's persisted over time at times. So we get to the female. So pardon me for going off the topic. I just wanted to give you a little historical reference. If nothing else, I'm good with that. I know. I was not there during the Napoleonic Wars, despite what you're thinking. Okay. I wasn't there I'm not the 2,000-year-old man. When you have a little time, listen to that one time. Mel Brooks and Carl Reiner. They did that as a routine at a party, and all of a sudden became an industry unto itself. Oh. That's how they developed the word cheese. You didn't know that? He looked into a vat of sour milk and went, "Oh, cheese!"
Funny.
That's how they started applause.
That's a good one.
You want to know how the word applause got started?
No.
When somebody did something good, thank you for asking. You should be a straight person.
What?
A straight man or a straight woman is the guy who sets up the comic.
Okay.
Okay. Tell us how it happened. Sure, why not? Okay. So when we would see something good happen back 2,000 years, they go, oh, a plus. Oh, you did something good. Oh, a plus. And sooner or later, it started to hurt. And so you went, moved your head away. And we turned a plus to applause. It's Mel Brooks. I understand you were there when Jesus walked. Yes. He's a lovely boy, came into my store, never bought anything. 12 guys with him. They didn't buy anything either. Quiet. Didn't dress very well. Bare feet and all that.
Have a store?
What?
You have a store?
He had a store. No, Mel Brook, the 2,000-year-old. You have to make a living. See, that's a setup line. You had a store? Little store. How to do? It's all right. It's the difference between the wonderful Frank Capra movie that everybody watches at Christmas, It's a Wonderful Life, and the Jewish version. It's a life. So it's okay. Moving on. So again, if you the labia majora, which has the hair cover, the labia minora laying within it, the opening itself they call the vestibule, and nothing else. Glandular structures that are related to or homologous or analogous to in the male bulbourethral glands, which are strictly about lubrication. The clitoris, again, the glands being like the head of the penis, the prepuce being like the foreskin in the male. So, and there's a certain amount of similar type, though not as certainly as abundant erectile tissue that are there. And again, that whole area that we refer to as the vulva is effectively the perineum, the diamond-shaped area between the pubic arch or symphysis, the coccyx, and framed on the ischial tuberosities that are there. So we have it with tissue and without. And that's the interesting part when we start to look at the within and without kind of effect. And you can see anatomically, if you go back and look at the one in the previous PowerPoint, in the male, there's a remarkable degree of similarities that are there. So when we hear about sexual reassignment surgeries or transition surgeries, it's not as big of a reach as people might think. I remember, and this is long before people even talked about that. We had a man back in 77 or 78 who was actively going to transition. Again, in Philadelphia at the time, there was a very, very large gay population and so that's where we were in the early onset of HIV in Philadelphia at that time. The two largest populations were San Francisco per capita and Philadelphia by far. So we were seeing HIV before anybody had the word. That was there. It was going around, and I've looked very, very interesting stories about that. But so they were in the process of doing, the plastic surgeon who was at our hospital was in the process of doing some of that work, some of the reassignment in the very, very early days. Very, very brilliant surgeon. Just yeah, I was there for that. Not all of them. He was there for everything. So mammary glands, this is where we discuss the breast. Even though they're present in both male and female, but the functionality obviously in the female, and RE milk production. Effectively, it's a modified sweat gland. If you go back and remember, we talked about glands, 3 different types. Typical sweat gland is called merocrine or eccrine. The secretion is basically liquid with something in it, salts, materials that are in it. The holocrine gland is the sebaceous gland, like for oil, depending on hereditarily, whether you have oily hair or dry hair, it's usually a function of that. The in-between gland, where a holocrine meant the whole cell was part of the secretion, was the apocrine gland, which had the apex. Remember, the cells had a base and an apex. The apocrine gland had the little top, which had a certain amount of fatty and a certain amount of liquid. Hence, this was the combination. So most of us believe that this was effectively an apocrine gland. People are always saying they don't really exist, or they do, I don't know. Has a number of lobes. It's a particular type of sweat gland. I don't go into the anatomy. The areola or areola, depending on how you want to pronounce it, is the pigmented area. They have a variety of ligaments. The underlying muscle, of course, is the pectoralis major. That's there. And whenever you do breast reconstructions, the question is whether you do it under or over. That, if particularly with breast augmentation procedures, or even with reconstruction procedures, with this unfortunately more common mastectomies and double mastectomies associated with the breast cancer glands. Okay. So the glandular alveoli, they're called lactiferous duct from lactation, et cetera, et cetera. It's undeveloped, but in nursing it develops during pregnancy and then even more so after delivery. Most breast size is related to fat deposit. So and I'm sure you know folks where their size has changed depending on weight changes, weight loss or weight gain, as most of us do. And you can see the typical cutaway that's here that kind of gives you an idea of the glandular structure. Here's the pectoralis major, etc. But again, substantially fatty tissue. It's the big nugget, just like in the male, except this is more common, unfortunately. I think statistically, the glandular cancers, what we call adenocarcinomas, because adeno means gland, and I'm sure I've said that to you before, are the most common cancers that we deal with, by and large. Skin cancers are probably statistically more prominent, more numerous rather, but most of them are basal cell carcinomas, and not really something that's scary. You basically just have to remove them. They're more cosmetic. Obviously, there are worse ones. These are different story entirely. So, prostate cancer is something that's usually not immediately lethal, much more long term. Breast cancer is not so. Breast cancer is unfortunately has a much higher degree of significant problem and metastases, and it has a remarkable amount of proximity, as we've talked about before, to the axillary nodes. You remember the lymph node discussion. So I mean, you can't. Any surgeon who's biopsying a breast lesion, they're always going to biopsy the nodes on that side, or else on both sides, because you just got to be sure. And you really can't make a determination if you're not sure with that at all. So it's the most common malignancy and second most common cause of cancer deaths in U.S. women. Again, lung cancer would still be number one, at least at the writing of this, and I think that's still true. It's an extraordinarily high number. Extraordinary. Epithelial cells in the ducts, and they are very prone to metastasis. They spread. That's the big problem. They can go almost anywhere. So we're looking at bone as a common, just like prostate. Brain is a common one. I mean, it's not good. Liver is common, not good. Okay. Risk factors. Early onset menstruation. I'm just reading them to you. Haven't researched this to let you know. No pregnancies or first pregnancies later. I don't know if that's true. Absence of breastfeeding. I think most people concur about that. Family history. But the other nugget is that the absence of risk cancer. Okay. 70% of women without any of those factors with breast cancer. Okay. That's where and I'm sure you covered this, or if you're taking genetics now or you've covered it previously, the breast cancer genes, and also the greater risk. I can't imagine how difficult a choice it must be for certain individuals to do that. My first cousin, his wife they discovered a cancer. She had positive for the gene. She elected to do the double mastectomy. This was some guy. They already had 5 children. So it's without any difficulty. When they did the reconstruct, they ran into a lot of problems. I mean, she had some really significant infection problems trying to do the reconstruct. I haven't seen her for a good 5 to 10 years, but much better, very athletic individual. So I don't know how that has all turned out. I mean, you're probably 10 years younger than I am. Okay. I know, early 80s or 90s. That's what I see, you guys. You're all saying the same thing. See, thank you. I said she's about 10 years younger than I am. I mentioned that she's only in her early 80s or 90s, because you all look at me like I'm 100 years old.
Got it. Right.
Now she agrees with me. No more self-deprecating humor. So that was significant, but I know they had a very, very difficult time with that. I am not, again, this is a while ago, I am not up on the recommendations vis-a-vis this with mammography and things like that. I don't know anything about it, so I wouldn't try to tell you or talk about the treatments and anything along those lines. Lumpectomy's not, and that's everything. That's the end of our anatomy class. Aren't you happy? You're ecstatic. Okay. So the assignment, just email me with a topic. I had cooked this one up because we had just finished this. And to me, in no specific, I can give you ideas of degrees of frequency, but in general, the infections that we suffer from, number one, respiratory, probably number two, skin, number three, urinary tract, which includes STDs, which is more of the focus point on this particular discussion. That's probably as good. You can look at statistics all over. From a hospital perspective, they deal a lot more with wound related. In fact, post-operatively, pneumonia would certainly be number one in the hit parade. But wound infections are very, in a hospital, the most common sources are urinary tract infections. They're mostly catheter related. That's a whole interesting issue into itself. There probably has been a trend away from indwelling catheters to catheterization, what they call straight cathing on need. Okay, rather than the indwelling ones they used to leave. For some people, they don't have a choice with regard to that. So that may be the most common, what they call nosocomial. Nosocomial is a fancy word which means hospital induced. It's not necessarily a fault. It means you didn't have an infection in that area and developed one during your time in the hospital. Hospitals are very sensitive about that because it costs them money.
So all we have to do is just email you a top.
Something if you're interested. I'd like to find out about what's up with COVID. I heard about RSV. Some type of skin condition that might be infection related. That's kind of where we're heading with this. I just do the STD thing because I think it's particularly relevant for young folks. But we've gotten a lot of information over the years, and I mean, it is so much different than I know. Here it goes. I don't probably say something. When I was your age thing. Okay.
100 years ago.
I was called an altacocker last night. You know what that means?
No.
Old fart.
Oh, why wouldn't they just say that?
But that was my best friend I was talking to.
Oh, okay.
He goes, I start telling him about what's going on. He goes, what are you talking about? You're an old fart. My former best friend.
Okay.
Yeah, I'm sitting here in Western Pennsylvania. He and his wife, we went to London for 2 days. Then we did a cruise around the Mediterranean from Barcelona to Portugal.
That sounds nice.
Yeah, doesn't it though?
Yeah.
And they're the ones who live in Florida. I'm here. I said, yeah, I would do the same thing. It's spit and snow and it's 28 degrees outside. It's the same guy. I go, you want to come up and visit? He goes, never. With friends like that, who needs enemies? But in that particular time, there was people infrequently would be the appropriate word. Rarely, might even be tending toward that, use condoms. Okay. The notion that you could get a potentially deadly disease that couldn't be treated or treated adequately was totally foreign. If anybody got something, they would go to the emergency room or to their doctor and they get a prescription for antibiotics and fixed up. They didn't know about HPV and the association with cervical carcinoma. Herpes. They heard about herpes infection, but made jokes about it. I mean, Saturday Night Live back around 1980 did a whole thing about that with a guy who used to be one of their people there in the Billy Crystal days named Tim Kazurinsky. Did a whole routine about that. Very funny, but not very. So that's kind of the jumping off point. So yeah, I do want suggestions. So I wanted to show you what this is about. This is what it started with. This is a pervasive disease that exists still and has become, and over time, and the big problem with many of these diseases is either the limitation or the absence of appropriate treatment. For years, penicillin was magic. You weren't allergic to, even if you were allergic to penicillin, other antibiotics were magic. Now we're starting to develop resistance. Yes, ma'am.
This might just be something I made up, but wasn't syphilis either brought over or taken over by Christopher?
Most likely.
And did he bring it over from Europe?
I think so.
Okay.
If you,
Over
Yeah, he brought it over from Europe, and then the natives, they sexually abused the natives here.
For sure.
And then because they had a limited, like,
With no use to
Yeah.
support it.
that's what spread and killed them.
And worse yet, and that wasn't the only disease that brought. Can anyone else explain why arguably 1,000 well-trained and well-armored Spanish soldiers could overcome tens of thousands of Inca warriors? Okay, despite having armor and being, they brought smallpox, they brought plague, they brought dysentery because it was awful. That, I mean, the natives were dying on their own, and it made it easy for the conquistadors to plunder and rape and all of that stuff. It was horrible.
So did the natives not have any disease that would impact?
Yeah, it's like bringing a total disease. Biological warfare has been around a long time. They invented catapults. What they used to do back in ancient Rome is they'd catapult dead bodies over the walls.
Over the wall, infect other people.
That's something I never learned.
Hey, you know what my mom said? You learn something new every day.
I've learned too many new things today at this point.
It needs to stop.
You never stop learning. That's I learned.
That's my
It's a hey, look, every day I'm here. I learn. You start learning how little you know, and when you start learning that, then you're actually becoming smart. But it's absolutely true. This has been around. So this, even though it was defined, and we still can't cultivate it, it's a non-culturable spirochetes are hard to grow because by and large they're intracellular. We can do the one even when we try to find Lyme's disease, it's a little bit more difficult. So, and they called it, that's where it got its name, Treponema pallidum, pallidum for pale. Treponema, there's a surgical instrument that was invented, interestingly, in ancient Rome called a trephine. It's like a circular saw blade, and they would put it, like, say, if they had to cut a hole in a bone and, like, get, string and like that. And so and they're still used. Trephines are still used to take, like, a plug out of bone. I've seen those used. So this is where it comes from. Most frequently, healthcare associated means nosocomial is certainly this. And the trouble, again, I mentioned this before with the urinary tract, when infections get in there, the urine and the bloodstream are in intimate contact. If we had somebody with a positive test for abnormal urine, we would cancel surgery because it would immediately get in the bloodstream. It would inevitably target where you're operating. Okay. Puerperal fever, which is childbirth fever, very, very famous. A lot of why we wash our hands came from that. And that's something I highlight. Did you talk about the historical aspects in micro with Semmelweis, Lister? Are they ringing a bell, guys? Okay, bells are not ringing. So they were the ones who just began to see the association between being clean and they would operate on people who never washed their hands, not wipe off the site. The instruments, they clean the instruments by taking an old towel and wiping them off. They didn't know from sterilization. Okay, so all of these types of things that are there. So when we talk about spread of disease, it's just to frame it, and the ones, and we'll start on Wednesday with this. First I'll look at your suggestions. Is the whole idea is there's basically 4 ways that disease is spread. Airborne, respiratory, COVID, for the most part, our understanding of COVID. Certainly there could be some on surfaces that you inadvertently pick up, but by and large it's respiratorily spread. Fecal to oral, which is just what it says, eat shit and die. Fecal to oral, right? And so you would pick it up from something you ate, whether it was food that was tainted or people who were not clean handling the food and you're eating it. Something we call zoonotic, which means it's passed to you from a different species. There's some subdivisions of that. Zoonosis is passed to you by someone from the animal kingdom. They fine tune it and say arbor-borne or arthropod-borne for an arbo type virus. So, basically fleas and ticks and that. Remember arthropods, all those phyla. invertebrates, insecta, arthropoda. My favorite tasty ones, crustaceans, lobster, arthropods. See, I remember that. And lastly, what we were sexually transmitted is misunderstood. Blood and body fluids or sustained intimate contact. A lot of these are HPV, probably the biggest player of them all. Okay, is spread not necessarily by intercourse, though it can be, is really a frictional component with a virus that's on your skin. And friction of skin to skin, and however you want to define it, creates tiny defects in the skin that allow that virus to implant. It's a wart virus. It doesn't go any deeper than your epidermis. It's confined there. So and staphylococcal infections, MRSA, are basically contact. So it can, and most time we look at them, we look at sustained intimate contact. The idea of intimate doesn't necessarily mean intercourse. It can be sustained physical contact, as opposed to bloodborne when you're coming in contact or through an open wound or shared needles and that type of stuff. Just to give you an idea. Such fun stuff to take us right through the holiday season. So if Santa comes to the house, don't come near me. So you wash your hands. You've been cavorting with the reindeer. Hey. It's a great line from Woody Allen. A sadistic, sodomistic necrophile, or is that beating a dead horse? You didn't get that?
It took a minute.
That was his first movie called What's Up, Tiger Lily.
See, I have a national anthem kind of